And so, the question that we're talking about today is this statement, not posed as a double negative as yesterday. HIV-exposed infants require lifelong follow-up in all settings, and that means first world or resource-rich, resource intermediate or medium-income countries, and low-income countries. And so this, I think, is a question that's very pertinent because I think we have very discrepant follow-up regimens across the world. Dr. Moffinson provided a very nice summary of the safety of pediatric HIV elimination and the growth in this population into the millions, which I'm sure we'll hear from our debaters. Because it's led us to a huge amount of debate and a lot of discrepant and confusing evidence that's accumulated over time. And so what's a clinician to do? So our great debaters today, I'd like to introduce them. Dr. Jennifer Zhao, who will argue the yes or pro side, is an infectious disease and med-ped specialist at Icahn University of Medicine, Mount Sinai, New York. And she's the director of medicine global health residency track. And her research interests are in pregnancy outcomes and metabolic complications of HIV-positive pregnant women and their children. And arguing the no side is Dr. Thanyawee Puthanakit, pediatric infectious disease specialist at Chulalongkorn University, Bangkok, former Fogarty Fellow, and current writing committee member for the WHO Pediatric Treatment Guidelines. And her interests for research include ART complications and long-term outcomes of HIV-positive and HEU children and adolescents. And so after yesterday's debate, we gathered and I said, okay, you guys are ready, you're gonna throw off the gloves and sling some mud, right? Because that's what a good debate is. And they said, we're Asian women. we don't do that. So I challenge you to summon your inside crouching tigers and hidden dragons and give us a great debate, and I'll try to moderate for one of the greatest debates ever made. Okay. So before we start, I think everyone's familiar from yesterday, but for those who weren't here, we'll take a vote, yes and no, pre-debate, and then another vote, yes and no, post-debate, and the person who has changed the most minds will be the winner. So I'll ask you all now, those who think yes, HIV-exposed infants do require lifelong follow-up in all settings, please raise your placard. Okay. Very good. And the no's, raise yours. Oh, it's very evenly split. Very nice. Lots of minds to change. So I will turn it over to Dr. Zhao.
Okay, I've been accused of being a tiger mom, so I think maybe I can do this. Tell me really quickly, this is, how do I advance?
Oh, just slide it down.
Slide.
Oh, and there's this too, sorry.
Oh, sorry. That advances?
Yeah.
Okay.
There you go.
This advances. And where's the pointer? This is the pointer? Got it. Okay. Okay, thanks for having me. This morning, as Jason said, I'm going to argue why lifelong monitoring of HIV-exposed uninfected infants, and I'm going to call them HEUs to be quick, is crucial. All right. As we all know, in the last decade, with the expansion of ART in pregnancy, the number of newly HIV-infected children has decreased precipitously over the last decade, while the number of HEUs, unfortunately, has actually increased dramatically worldwide. So what do we do with these HEUs? Our question, do we need long-term monitoring of them, lifelong and in all settings? Well, expert panels, which include many of you in this room already today, seem to think so. The United States Department of Health and Human Services panel has actually recommended that the follow-up of children with exposure to ARVs should continue into adulthood because of the theoretical concerns regarding the potential for carcinogenicity of nucleoside analog ARVs. Information regarding such exposure should be part of ongoing permanent medical records for children, particularly those who are uninfected. And our Spanish colleagues have stated that the potential long-term toxicity in healthy exposed infants and the continuing emergence of new ARVs make it advisable to devise a mechanism whereby the identification and registration of potential adverse long-term effects of such exposures may be recorded. And lastly, our French colleagues have also advocated for the long-term follow-up of symptomatic children. So there you have it. We can all go home now, except I'm supposed to fill 15 minutes of a conversation here. So let me attempt to lay out some of the evidence behind some of these recommendations. Let's take a step back and sort of briefly consider the Barker hypothesis and this notion that adult chronic diseases may actually have fetal origins. So current thinking right now is that the in utero period represents this very critical window whereby changes, and I'm talking about changes like drugs, toxins, stresses, how do you do the pointer? Infection, can actually alter the fetus's biological setting, i.e. the fetus has to respond to these stresses by reorganizing, adapting at a cellular, epigenetic, and sort of organ level reprogramming. And all of this reprogramming then plays a role in the development of chronic disease in adulthood. So let me give you some examples. For instance, in utero maternal infection, such as toxoplasmosis, influenza, has actually been shown to be associated with adult schizophrenia. In utero exposure to things such as IUGR, intrauterine growth retardation, has been associated with the long-term development of insulin resistance, type 2 diabetes, and cardiovascular disease. And let's not forget the dreaded DES story, where in utero exposure to the drug diethylstilbestrol, which was actually originally prescribed to prevent abortions or miscarriages, was later found to cause cervical vaginal breast cancer and infertility. So what are some of the short and long-term concerns that we have which are specific to in utero HIV/ARV exposure? Well, there's concerns for congenital anomalies. There's a large amount of data showing concerns centering around SGA, mitochondrial toxicity, preterm birth. We know that SGA and preterm birth can cause metabolic complications, which then may translate into adult onset cardiovascular disease or diabetes. In the same vein, mitochondrial toxicity has similar effects on metabolism. How about neurologic and cognitive complications? Well, we know that mitochondrial toxicity can cause neurocognitive complications, and of course, preterm birth has neurologic complications. Then there's concerns for bone health with in utero tenofovir, as we talked about yesterday. There's concerns for mental health problems also in HEUs as they grow older. And last but not least, there are concerns for NRTIs and genotoxicity. There's clear evidence for that. What we don't know is whether there's a potential for this genotoxicity to translate into later life malignancy risk. So let's unpack some of these concerns and these pathways around in utero HIV/ARV exposure. We'll begin with HIV/ARV and its clear association with preterm birth. We have a long list here, which is by no means exhaustive, really clearly demonstrating that preterm birth is associated with PIs, either boosted or non-boosted, first trimester PIs, and combination ART. So I'm going to just highlight a few of these. There was a large pooled analysis which combined data from the US, European Collaborative Study, and the UK's National Study of HIV in Pregnancy and Childhood, and they showed an increased risk of preterm birth after adjusting for confounders with heart. Then we have the large Botswanan study of over 33,000 HIV-infected and uninfected pregnant women, and they showed higher rates of preterm delivery, and the fact that HIV-infected women were at increased risk for small gestational age outcomes. Now, my esteemed opponent may try to dissuade you from my opinion by saying, well, by the time HEUs are diagnosed as HEUs at 4 months, look, most of the significant medical issues they might have, such as prematurity, low birth weight, congenital defects, look, they're already identified and managed appropriately. So why do we need to follow them long term? I'd like to remind you all that SGA and preterm birth actually have long-lasting sequelae, some of which include adult metabolic and cardiovascular diseases. This is a long list also, by no means exhaustive, but you see here the seminal paper by Barker et al. In 1989 from The Lancet, all the way up to more recent large cohorts like the POPS cohort, which time and time again show that lower birth weight, lower gestational age, puts you at increased risk for adult onset ischemic heart disease, hypertension, and diabetes. But outside of this SGA prematurity pathway, we also know that in utero HIV ARV exposure actually perturbs your intermediary metabolism directly. So there's data in Cameroon where we've shown that HEU infants are increased risk for lower preprandial insulin early in life, as well as altered fuel utilization, abnormal fatty acid oxidation, and higher rates of higher abnormal acylcarnitine profiles. What we don't know, though, is whether these early derangements in your intermediary metabolism actually put you at increased risk for late adult onset metabolic complications. Well, what are some other concerns linking ARVs and preterm birth? We're all pediatricians here. We all know that preterm birth is well documented to cause neurocognitive sequelae. But in addition, independent of this preterm birth pathway, in utero ARVs may confer an independent risk for neurocognitive dysfunction later in life. There's a very elegant study in Thailand, led by none other than Dr. Puthanakit, I hope I said that right, where she very systematically looked at the neurodevelopmental scores in HEUs compared to HUUs. And what she found was that HEUs had significantly lower verbal IQ, full-scale IQ scores, as well as the bead memory component of the Stanford Binet Intelligence Scale. All right, we've talked a little bit about SGA, prematurity. Let's talk a little bit about congenital defects, because Dr. Puthanakit's going to tell you that congenital defects are found pretty early, within the first month of life. You don't need to follow these people long term, because we're going to find out that they have that already. But let me remind you that not all congenital defects are evident at birth. The French perinatal cohort and the nested Primeva randomized trial showed that first trimester AZT exposure was significantly associated with congenital heart disease. But what I want you to notice is that the differences in the diastolic function between the exposure groups was not actually evident until 12 months of age, not birth. All right, let's switch gears to mitochondrial toxicity. There's a ton of data sort of detailing ARVs and its effects on the mitochondria. A lot of them has showed abnormal mitochondrial DNA levels, decreased enzyme levels, decreased complex 2 and 4 levels, and increased mitochondrial mutations. And I think the most alarming data has come out of the French perinatal cohort that we all know of, where the authors reported an 18-month incidence of neuromitochondrial disease at 0.26% in their HIV-exposed children. That compared to a mere 0.1% in the general pediatric population. I don't need to talk to you guys too much more about bone mineral content, because we talked about it yesterday, but yes, there's concerns for that. I'm just going to highlight the FACT study that was recently published, where they looked at infants and found lower bone mineral content in association with maternal use of tenofovir. Again, we don't know if these early signals of bone mineral content decreases will actually translate into worse things like bone fragility or fracture increased risk when they're adults. How about mental health problems? Well, there's not a lot of data that have followed HEUs out long enough to look at that. But in the US CASA study, amongst HEUs, the prevalence of any psychiatric disorder was pretty high, 57%. And actually, mood disorders increased over time when you followed them longitudinally. This is compared to an HIV-infected cohort. And then the FACS cohort sort of found similar results, where the prevalence of mental health problems was higher in HEUs than actually HIV-infected kids. And last, I just want to remind you that things like schizophrenia don't actually present until late in life. So it's really crucial to follow these HEUs, because you're not going to find schizophrenia in a 7-year-old yet. All right. The last concern I want to talk about is this worry about NRTIs, in specific AZT and tenofovir, and how they can confer genotoxicity. There was a study that looked at infants exposed to AZT and 3-TC and compared them to HUUs, and they found much higher rates of glycophorin A somatic cell mutations, and these mutations actually were persistent even at a year of age. And then we have another study out of France where we saw zidovudine-exposed kids with much higher rates of aneuploidy than either tenofovir-exposed kids or HUUs. What's really concerning is that both AZT and tenofovir-exposed kids actually exhibited higher altered gene expression for DNA repair. So the question then is, are these genotoxic signatures going to lead to the same sort of upregulation in genes that we see in tumors? Remember, we haven't followed these kids long enough to really rule out malignancy risk. So 2 things that my opponent's going to say that I'm going to just try and make sure there's no confusion about. She's going to say lifelong follow-up will actually increase stigma to HEU infants. And I would say stigma is a small price to pay if lifelong follow-up uncovers a serious late adverse effect of in utero ARVs. What she may also say is, look, lifelong follow-up may not be warranted in all settings. With the scale-up of PMTCT and pediatric ART programs, there are just too many competing resources in resource-constrained settings. So I have a response, but instead, I'd like to leave you with the very wise words of our highly respected colleague, Dr. Lynn Moffinson, and Dr. Heather Watts, who's not here, who say, given that the HIV burden in women is greatest in resource-constrained countries where rapid expansion in ARV use in pregnancy is expected with implementation of WHO guidelines, there's an ethical imperative to systematically and critically evaluate the safety of these recommendations for the fetus infant, both in terms of potential teratogenicity, but also long-term outcomes. I know you have a very difficult decision ahead of you as you grab for those red and green cards. Just remember, vote yes, vote yes. Thank you.
May I have my slide? So, my job today is to convince you that HIV-exposed and infected infants require lifelong follow-up in all settings for no. And I would like to address 3 keywords, respectively, on HIV-exposed, lifelong, and all settings. So what are the exposures? I think that everyone in the room agree that HIV-exposed and infected infants, they are exposed to many things. They are more at risk comparing to HIV and exposed and infected infants. They're exposed to HIV virus. Mothers have low maternity immunity. They might have non-breastfeeding and lower antibody transfer from mother. They're, of course, exposed to antiretroviral drugs, either in utero and neonate. They might have psychosocial factors that make them vulnerable, and also they might live in a family that's exposed to more infectious disease. I all agree with my esteemed opponent that they are exposed to more risk, but the risk doesn't mean straightforward that you need lifelong treatment. What we should do is we should early on modify this risk and reduce the risk and allow them to live their healthy life. For HIV-exposed and infected infants, for non-breastfed population and breastfed population, in reality, before you can make diagnosis that they are HIV-exposed and infected, you are already close following them up in the first 6 months at least in HIV non-breastfed population, or for breastfed population, you will follow them up until they're stop breastfeeding, and then you make diagnosis. So the most vulnerable time, the first 6 months or the first year of life that they might vulnerable to increased risk of morbidity or mortality, you already close follow up them. For risk of congenital anomalies, I agree that there are evidence that they have increased risk of congenital anomalies, but you don't need to follow all of them. You can focus and put your resources to follow up with the patients that have congenital anomalies or SGA or preterm at birth. For example, the risk of congenital anomalies in the WIS cohort, when the time that we use only ACT monotherapy, the prevalence is around 3.6%, which is a little bit higher than HIV unexposed. In the recently data from the FACS cohort, when the combination therapy was using during pregnancy, the prevalence of congenital anomaly is 6.8%. So it's much easier to focus on less than 10% of the cohort and have a good follow-up in the patients who are at risk and need follow-up. Don't need to follow all of them. And the risk of ARV exposure in utero, my esteemed opponent, actually in her mind, she said in utero tenofovir expose is not associated with poor fetal long bone growth, and she will present her data. So actually in her mind, there is something secret in her mind that she don't tell us in a period ago. And what is the risk of impaired immunity? This one might be a real risk because in mother might have nutrition deficiency, might have lower antibody transfer to baby. So we have an evidence that functional result of HIV exposed and infected, they might have increased infection with encapsulated bacteria or higher rate of mortality and morbidity. So what you would do? Would you wait and see and do a lifelong follow-up, or you would like to intervene? We might be able to intervene them, such as give immunization or give prophylaxis in order to reduce their risk, rather than wait and see and describe it. So in terms of risk of invasive pneumococcal disease data from South Africa, it's the data that they do analyze from the database on the pneumococcal disease. You can see that in 2009, before vaccination, HIV unexposed and infected have a rate of invasive pneumococcal disease 31 out of 100,000 population. HIV unexposed infected have about 4 times increased risk, but HIV infected has about 40 times increased risk. But we can intervene. After 2013, after giving vaccination, at less than 6 months, the risk of HIV exposed and infected is declined to about 57 per 100,000 population. And after 6 months, the rate of invasive pneumococcal diseases is quite similar to HIV unexposed and infected. So we should focus on prevent them from infection. And also other childhood illnesses or malaria in the high burden of malaria disease. Cotrimoxazole prophylaxis can reduce morbidity and mortality among HIV exposed and infected in the first 2 years of life. It can reduce the incidence of malaria and also probably might have impact on the incidence of diarrhea and pneumonia. There are ongoing studies of cotrimoxazole among HIV exposed and infected in Botswana and in Durban, try to see the effect of cotrimoxazole prophylaxis to reduce the incidence of the childhood illness. How about TB disease, tuberculosis? Data from South Africa showing that HIV exposed and infected have higher risk of tuberculosis. However, there are studies, Impact 1041, trying to give primary isoniazid prophylaxis to give ahead of time to prevent them from getting the disease. However, in that study showing that giving primary isoniazid prophylaxis did not reduce incidence of TB disease. Therefore, even we do a long-term follow-up and give prophylaxis ahead of time, we cannot prevent. But the key issue is that we should give anticipatory guidance to mother and tell them that the infant or baby or children, when they're growing up, they have more risk of exposure to TB. And if they have exposure to tuberculosis, mother or caregiver should seek for secondary prophylaxis or evaluation of TB to reduce the risk of TB disease. And in terms of developmental outcomes of HIV exposed and infected, this data from US cohort that follow up during the early infancy period using Bailey scale to evaluate the different domain of development in HIV-exposed infant. And this data are showing that all domains of cognitive, language, motor, or social, emotion, adaptive behavior, it's not different from the norms of HIV-negative patients. And also in long-term neurocognitive function in HIV-exposed and infected during childhood, the norms of the verbal IQ or performance IQ is around 90 to 100 score, which is quite close to the population norm, or lower than population norm, not more than 1 SD. The reason that my opponent talked about my study on neurodevelopmental outcome, what do you think? Why it's different from US? The big difference is that in Thailand, the ART for adult is just widely available in the last 10 years. So in my cohort, more than 50% of the children was lost either their parents, mother or father. So the situation will be different. So we have to focus on keep their father and mother alive in order to provide a good environment for them to be able to grow up and have a better neurocognitive function. Because you can prove from the US cohort that if they live in a family or in the environment that nurture them to be able to grow up, you can have a normal neurocognitive function. So, lifelong follow-up, what? Do you have enough resource? Do you have enough energy? Do you have enough scientific justification to do that? So I think we should focus on maximize health outcome of HIV-exposed and infected during the first few years of life and let them live their normal life and let the mother feel like the child is normal, not feel frustration that their babies have something wrong. The first thing that I would like to do is to make sure that you keep your parents alive in order to be able to nurture them, need a nutritional support during the first few months, especially in non-breastfeeding population or breastfeeding population, to make sure that they have good nutrition supports, give immunization for them, give cotrimoxazole prophylaxis, educate them that they have increased TB risk and need to find the appropriate intervention at the right period. And also anticipatory guidance on psychosocial issues. And I think in this room you have an experience that giving the result of HIV DNA PCR to the mother. And one of the patients said that, "Doctor, thank God that my baby is not infected. This is the best news that I have since I learned that I'm HIV positive. My child is normal, right?" What do you say? You say they're normal or no? I think everyone in the room say, yes, your baby is normal. This is the way that you motivate mother to take good care of herself and also have an energy to go forward in their life. And also in the terms of stigma and disclosure of mom, I have a patient that come to saying that, "Doctor, since my son is not infected, can you delete HIV exposed from his health record book? I don't want him to have stigma when he grows up or when he go to school or even go to other hospital." Or in another scenario, my mother-in-law will take care of my child. I'm not ready to tell her about my HIV status. If my child is not infected, I don't need to tell her, right? Can I just ask her to taking care of my baby without disclosing my status and also disclosing that a baby was exposed? So I think this is the context that you have to think about before you make an assumption that all children need long-term, lifelong follow-up. And the last point is in all settings. In 2013, 1.5 million women living with HIV gave birth, and with the target elimination of PMTCT, we know that in the future will be less and less patients that are infected. However, in real life, we still not have enough energy or resources to cover all. Now we should focus on doing better in terms of taking care or detecting HIV-infected children, not talking about the 90% or 95% of HIV exposed and infected. And can it be done in all settings, in US, in Europe, or in other parts of the world? And in the DHHS guideline that my opponent quote that follow-up of children with exposure to ARVs should continue to adulthood because theoretical concern regarding potential of carcinogenicity of nucleoside analog ARV drugs. And what is the strength of the recommendation, which I think, if you don't believe me, you can believe Lynn Mortensen, because it's optional by expert opinion. And how about in the UK, long-term follow-up of HIV-exposed and infected? There are studies in the UK that the healthcare workers try to contact and enroll HIV-exposed and infected who were born in UK between 1996 and 2004. They try to do a long-term follow-up and contact about 2,000 eligible children. What percentage that you think that they can approach and ask them to follow up? What do you think? Okay, so the result is that 33% enrolled to the study. 5% patients decline, 25% cannot contact. But interestingly, 37% or 1/3 in the UK said that they don't have enough resources to seek or follow up these patients. If you're in the UK and you cannot do it, so I don't think that we can do it in middle incomes or resource limited settings. And that study conclude that comprehensive clinic-based follow-up of HIV-exposed infant is not practical. You have to find other ways. And in Rwanda, comprehensive child survival program with the health statistics that they have higher rate of background infection, they approached using multi-facet package of comprehensive intervention to maximize HIV-free survival, including have nutritional support, giving home visit, prevention of major childhood disease, and the survival retention probability is quite good. And in reality check, there are competing tasks. 7 out of 10 pregnant women received ART during pregnancy. 30% of them that we not reach them yet. 200,000 HIV-infected infants still infected. We cannot prevent them all. And there are a big gap in early HIV diagnosis, big gap in cotrimoxazole prophylaxis. So, in summary, I think HIV-exposed and infected children have increased morbidity and mortality risk compared to HIV unexposed. However, the way to go is to integrated comprehensive intervention, focus on improve their survival during the first 5 years of life, and appropriate resource allocation in the context of the whole PMTCT or the Pediatrics HIV services. So HIV-exposed and infected infants require lifelong follow-up in all settings. I would say no. But HIV-exposed and infected infants require comprehensive intervention during first few years of life, focus on survival, especially in resource-limited settings. I would say yes. Thank you.